So now I'm going to go over the different parts of the anesthesia machine and what they do. So this is our anesthetic machine. We use a rebreathing system, which I'll talk about in a moment. First thing I want to bring up is our oxygen tanks. We have our H tanks here, and then we have our smaller E tanks down here. And this holds the majority of our carrier gas, which in this case is oxygen. So what we would do is we would turn this on. It goes into our pressure regulator, which will reduce the pressure of the gas to a more usable, safe level, which is about 40 to 50 psi. And then it's going to go down into this intermediate tube down here, and I don't know if it might be a little hard to see, but it wraps around here and goes into our flow meter. Our flow meter kind of tells us at the rate of how much oxygen is going to be in the rebreathing system at a time, and it can also further lower the pressure of the gas. So if I turn on my oxygen, I have at my 50 psi, and then I can turn on my flow meter, and this little ball here is the indicator of how much air is being put into the machine. So turn that back off, flush the system. This is our oxygen flush valve, which I'll talk a little bit more about in a moment. So next, when the gas starts from the bottom of the flow meter and goes into the top and exits out the back. It's a little hard to see, but this tube here is where it exits out. And then it goes into our vaporizer. So this is a precise vaporizer. We have a little knob here that lets us adjust the rate of our gas input. So the way this works is there is a liquid anesthetic in here. Most of the time it's isoflurane. And when our carrier gas goes in here, and we turn this on, our liquid gas is converted, vaporized into, or not our liquid gas, our liquid anesthetic is vaporized into gas. So that is mixed with our carrier gas to form, it's called fresh gas. And the isoflurane anesthetic can't actually leave this system until it's mixed in with our carrier gas at a controlled rate. So it will leave out one of these tubes here again into our breathing system, or breathing circuit rather. So this is when we would talk about our rebreathing system. So there are two types of systems for an anesthetic machine. There's rebreathing and then there's non-rebreathing. So this is rebreathing, so I'll talk about that first. So basically it's one big circle. So we have our inhalation unidirectional valve, it's a one-way valve, and when our oxygen and our isoflurane, when it all comes into here, it's when the patient inhales, the valve opens, and it goes into our inhalatory tubing, goes all the way down into what's called our Y piece, and our Y piece is connected to the ET tube that's in the patient, goes through the ET tube, enters the lungs, enters the bloodstream, and then when the patient exhales, they bring it with them, waste gas and stuff like that. That exits out the lungs into our Y piece, up the exhalatory tube, and then into our exhalation unidirectional tube. And then the carbon dioxide is taken out of there and deposited directly into our carbon dioxide absorber canister. So it's filled with soda lime, which is an absorbent granules, all these granules here. And this absorbs the carbon dioxide so that it doesn't re-enter the system and the patient isn't rebreathing it back. And then the rest of the gas is circulated back, and it goes into a big circle once again where it's being inhaled and exhaled. So essentially they are rebreathing the same air that they inhaled and exhaled, minus carbon dioxide. So the non-rebreathing system, it doesn't do that at all. Instead of having recycled air cycle through, it has fresh air being sort of pushed into the patient at all times, so the patient doesn't have to work as hard. It's constantly getting fresh air, fresh gas. gas, fresh oxygen, and you don't have to worry about the recycling of the air. So that's usually used on patients that are 2.5 to 3 kilograms, so like smaller patients, and then patients that are a little more higher risk, so you don't want them rebreathing recycled air, you want them getting fresh oxygen. So a few more things to talk about. We have our pop-up valve over here, so you can close it and open it, and it's essentially our like an exit port for excess gas. So any isoflurane that the patient is not breathing in, we don't want it just kind of hanging around in the machine. We don't want it like ending up in the air for us to breathe. So it's going to go ahead and go into this tube here. It's a little hard to see, but it ends up in this white tube and all the way up into our scavenger system, which basically takes all the excess anesthetic gas and gets rid of it so that we don't have it floating around the hospital. Our oxygen flush valve here, if you press it, it releases a large amount of pure oxygen right into the reservoir bag so that the patient can breathe that in. It also bypasses the flow meter and the vaporizer, so it's a quicker way of giving the patient like a burst of oxygen. What else? Our reservoir bag. It's basically, as the name suggests, it's a reservoir for air, so there's constantly going to be air just like hanging out in there just in case it's needed. And it's also a good indicator to a technician how the patient's respiration is going, because it'll inflate and deflate as the patient is breathing. It's also helpful when you are doing when you are inflating and deflating the ET tube, the cuff. You want to be able to give breaths so that you can hear if there's any leaking of the cuff. And then a few more things I just forgot to mention in my first video. We have our pressure manometer. So this basically tells us the pressure of the gas in the system itself, and then by extension, the pressure in the patient's lungs and airway. So it's measured by centimeters of water. So when you press down on the reservoir bag, you can see that the arrow moves a little bit. And then we also have our cuff syringe. This is used to basically inflate or deflate the ET tube's cuff, either before surgery. When you're placing the ET tube, you want to make sure that there's no gas leaking. You want to make sure that the cuff is correctly inflated. And then at the end of surgery, when the patient is being extubated, you want to make sure that the cuff is deflated so that you don't cause damage to the trachea when you pull the ET tube out. So this is here we attach it to the machine so that we always have one handy. A few more things to talk about outside of the anesthetic machine in general. There are oxygen masks. So it's put on the patient's nose and mouth, usually like their snout, and it can deliver air to the patient when an ET tube is not applicable, or if they just haven't been able to put the ET tube in yet. And then the chambers that we would use to induce a patient using anesthetic gas. That's for patients that you can't get a catheter into them. They're just not manageable. You can't handle them at all. So you put them in this. It's kind of like an aquarium, like a tank, and it has ports in it where you pump gas into the tank itself, and the patient becomes anesthetized that way, to the point where then you can intubate them and place a catheter and continue on with the procedure. So now I'm going to demonstrate how to perform a leak test on an anesthesia machine. So first thing I'm going to do is I'm going to turn our gas on, and I have my tubing and my 2-liter reservoir bag. So what I want to do first is I want to take our pop-up valve and shut it completely off. And I'm going to take my hand and place it over the opening of the tubing. And I want to take my oxygen flush and go ahead and fill the bag. And you want to fill it to about 20. So when we're looking at the manometer here, so when I have it occluded like this, you can see that it's not going, it's not moving from 20 centimeters of H2O. So that means that there is no leak. If there was a leak, then I would go about trying to find that, checking all of the tubing, checking the bag, making sure that everything is working the way it's supposed to be. But as you can see, this anesthesia machine is working just fine. So now that our patient is in surgery, we can go ahead and start with one of the monitoring equipment. So I've already placed the capnograph, I've attached it to the ET tube of the patient and the breathing circuit, and what that does is it measures the amount of CO2 that the patient is breathing in and out, and also the amount of CO2 in the ET tube and the breathing circuit, which is ETCO2, and it also measures the patient's respiratory rate by breaths per minute. Next, I'm going to take our pulse oximeter, our pulse ox, and attach that. And this measures the SO2, which is the percentage of hemoglobin in the saturated with oxygen. So I'm going to take this probe and put it onto the patient's tongue, and what it does is it analyzes light that passes through tissue. So you want to place it on an area that has little or no hair, like the tongue, the pin of the ear, the toe, prepuce, anything like that. Next, I'm going to put on our blood pressure monitor. We use an oscillometric blood pressure monitor. So I want to place this cuff on the patient's artery or over the patient's artery on a limb. You can also do a tail too. And what this does is when you turn it on, it inflates and deflates, and it measures the change in pressure that you would get when the artery is pulsing underneath the cuff. And that measures the systolic, diastolic, and mean pressures of the patient, as well as heart rate. So we'll go ahead and turn that on so we can start. Next, we have our ECG, our electrocardiograph. And what this does, we're a little tangled here. It displays the electrical impulses that are generated by the cardiac conduction system, which initiates each heartbeat. And that pattern of electrical impulses, that's the heart rhythm, and it will display it up here. Right now it says the leads are off, these are the leads. So when we attach these, it'll give us a display, and each heartbeat will be accompanied by an audible beep, so we can keep track of that. So our leads go on different parts of the body. So our left one, or our white one, goes on the front right leg. Our black one goes on the front left leg, and then our red one goes on the back left leg. So for the two front ones, you can kind of picture holding a newspaper, the black and white. That's how you remember that they go on the front. And then white rhymes with right, so you put that on the right. And then for the red one, you just want to remember red rear, and then just remember that it goes on the left. So go ahead and do that. Take our alcohol and wet those. And then lastly, we have our temperature probe. This measures the internal core temperature of the patient, and it goes down into the esophagus. So we'll go ahead and do that. And it measures, or it keeps track of the temperature up there, and we want to check that every 10 to 15 minutes to make sure that the patient's temperature isn't dropping too low during surgery. So in addition to the other anesthetic monitoring devices that are in the surgery room, there's also a few other ones that I haven't discussed yet. The endotracheal tube, the esophageal stethoscope, and gastric tube for gastric intubation. So first we'll talk about the endotracheal tube, the ET tube. So this is used to deliver air and anesthetic gas directly to the lungs from the anesthetic machine, and it also protects the airway during surgery. So when you are looking to find the correct size for an ET tube, generally for cats you use between a 3 and a 4.5 millimeter tube. So this is a 4 that I have right here for a cat. And for dogs, a good rule of thumb is, let's say you have a 20 kilogram dog, they would get between a 9.5 to a 10 millimeter tube. And then you would subtract or add 1 millimeter per every 5 kilograms of the patient, and that's a good indicator of the size for the patient. When you are deciding if the tube is long enough, it's the appropriate length for the patient, because you don't want dead space if it's too long.
you want to measure the tube from the thoracic inlet to the tip of the nose, and that's a good indicator that the tube is the correct size. Before you intubate the patient, you want to check your tubes to make sure that the cuffs are not damaged. There's going to be no leaking. So I'm going to take my tube, this is a 7, and I'm going to inflate the cuff with my syringe. And just looking at it, you can see that it's retaining its shape. To check to make sure that there's no like little leaking anywhere going on, we want to submerge the cuff into a cup of water and see if we get any bubbles. The bubbles would indicate a leak. And I'm not seeing any bubbles here, so I would assume that this cuff is intact and not leaking at all. And then of course we want to use our lubricant to make it easier for the tube to go down. We would lube the cuff itself and the tip of the tube. Next we'll talk about the esophageal stethoscope, and you would use this to auscultate the heart when you can't use a conventional stethoscope, or when, let's say, there's draping over the patient, you're not able to really have access to the patient's chest because there's surgery going on. So it's a thin, flexible catheter that has an audio device on the end, and that device electronically amplifies heart sounds. So you would place that down the esophagus to about the 5th rib, and you would adjust it until you can hear the heart. Lastly, for gastric intubation, you would do this during surgery to evacuate air or fluids that are retained in the stomach. And very much like the ET tube, you would place it down the throat in this case, instead of the ET tube where you would place it down the trachea into the lungs. You would place the gastric tube down the esophagus, the oropharynx, into the stomach. Okay, so this is my preceptor, Linda. She's a licensed veterinary technician, and from now on, she's going to be observing me throughout the rest of my videos. So she'll either be holding the camera or holding the patient, or just be off camera.
So in this video, I'm going to demonstrate how to place an IV catheter in the cephalic vein of a patient. So I have my equipment here. I have my clipper blade for clipping the area. I have my chlorhexidine and alcohol soaked gauze to clean. I have my 22 gauge catheter, my induction drug, and my 2 flush syringes here. I also have extra gauze so I can grasp the tongue and clean anything if needed. I have my vet wrap, and then I also have a cap for the catheter. So I'm going to first go ahead and clip the area. And I want to get underneath too, so we don't actually, wax the patient when we take his catheter out later. Okay, and I just wanted to give myself plenty of room there, so I may have gone a little bit more, but that's okay. More is better than less, so I'm going to put that over here. And now I'm going to put this hair. I'm going to take my chlorhexidine soaked gauze, and using an aseptic scrub, I'm going to start from the middle and go out. And I'm going to do that 3 times, and I'm going to also switch off between the chlorhexidine and the alcohol. 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 Okay. So I'm going to now take my gloves off since everything is aseptic. Since the area has been cleaned and prepped. And so our patient is right here. I'm going to open my catheter.
We're a little short at the moment. Is it possible to
and I want to flush it through, so I'm going to take my cap off.
She could set that up for you. Thank you so much. All right, bye-bye.
Flush that through. My cap back on. Alright. So my assistant is going to go ahead and roll off on the vessel. And I want to take my catheter. And I want to make sure the bevel is up, and at a 45-degree angle, I'm going to go into the vessel. And I want to look for that flash. Force that in a little bit more, and advance that in. I'm just going to hold off, and I want to take my cap and put that in there. So nobody gets stabbed. Alright, so now I'm going to take my first piece of tape. It's going to be the skinny one. And I just want to put it so that it stays in place. So I'm going to put it skinny side up. Underneath. And that's going to go over. And that's there. And around. Okay. And before I do any more of my taping, I just want to make sure that my catheter is indeed in the vessel and not just next to it. So I am going to take my cap off and then flush it. And what I'm looking for is to make sure that there's no blowing of the vessel over here, and that would mean that the vessel, so we know it's in, that would mean that the catheter is actually next to the vein and actually not in it. So I'm going to go ahead and finish my taping. I'm going to take my little tape right here, put that underneath, and that's going to go in a crisscross, and that's going to anchor the just fix that a little bit. It's going to anchor that there. Tape has lost its stickiness a little bit, but that's okay. And now I'm going to take my last piece of tape, and it has a V in it that I've cut in there already. Put that underneath, and that's going to wrap around, complete our catheter. And we don't want to make sure that our tape is not too tight because we don't want to break off circulation. So that's how you place an IV catheter. So now I'm going to demonstrate how to place an IV catheter in the saphenous vein of the patient. So I have my equipment over here. I have my clipper blade, my 22 gauge catheter, my induction drugs, and my flush. I have some extra gauze here in case I need it, my catheter cap, my vet wrap, and then I have my chlorhexidine soaked gauze, and then my alcohol soaked gauze, and then my tape that I'll be using to tape in the catheter. So first thing I'm going to do is shave the area. Just see where I am with things. There's a lot of fluff over here. Okay, good. So I can see my vein right there. Get this out of the way. So I'm going to take my chlorhexidine gauze, and I'm going to go in a circular motion, starting in and going out, and I'm going to alternate between using that and the alcohol, and I'm going to do this 3 times. And then the area is a little wet, so I'm going to take a dry gauze and just wipe that away so that my tape doesn't stick. Okay. So now I'm going to take my catheter and flush that through. So in order to get, make sure I don't get hair on the site, I'm gonna take those off. I want to make sure I have my bevel up. And at a 45-degree angle, I'm going to go into the vessel. Sorry, hold on. It's a little woolly. A little flash, but I just want to make sure that's actually a true flash. I want to make sure that I'm moving here. I'm just going to hold off. I'm going to put my cap on. Now I want to put that over here. I'm going to take my first tape and sticky side up. I'm going to go underneath. Hold on. Hold on. Okay. And before I do anything else, I want to make sure that my catheter is actually in the vein and not next to it. Some hair caught in there. Okay. Thank you. So I'm going to take my flush. If you wouldn't mind just holding off. And I'm looking for any, to make sure that it's not blowing. It looks like we're good there. So I'm gonna put my cap back on. I'm gonna finish my taping job. I'm gonna take my tiny piece of tape here. It's very hairy. It's gonna go underneath again, sticky side up. And do a crisscross. Okay. And then my last piece of tape is also going to go under. And that'll go around. And then I also want to make sure that my tape is not too tight. And then we can proceed with going ahead and inducing our patient. So on the last thing we do to make sure my tape stays nice and clean during surgery, I'm just going to put a vet wrap, actually I'm going to put it this way. Put a vet wrap around, and I want to make sure that the hub is, so much hair.
It is fluffy.
I want to make sure that my wrap is, I'm going to fix that in a minute, sorry. I'm not in the way of my hub so that I can induce drugs, and then we are ready to go into surgery. So now I'm going to do a subcutaneous injection. This is going to be the Lyme vaccine. It's going to go into the left hip of this patient. So I'm going to take my cap off. The bevel wants to be up. I'm going to grasp a bit of skin so that I have a kind of like a tent here, and I'm going to inject my needle in, pull back so I know I'm not in a blood vessel, and inject that. So now I'm going to give an IM injection. This is ET Pramazole. It's going to reverse dexdomitor, which we have used to anesthetize this cat. So when you're giving an IM injection, you want to stay away from the sciatic nerve, which runs along down here. So I'm going to stay away from there. I give my injection. Make sure I'm in a muscle when I do it. And I'm going to pull back a little bit, make sure I'm not in a vessel. Go ahead and do that.
Okay, so now I'm going to do an intravenous injection. I first need to get blood from this patient, so we're going to use a butterfly. It's okay. Really fluffy. Okay. And I'm going to use saline for my injection here. First. So now I'm going to get my saline. And I'm just going to inject that in, right into the vein. Good boy.
So now that our catheter has been placed, I'm going to go ahead and do our anesthetic induction. So first I'm going to make sure that our catheter is patent. I'm going to just flush it very quickly. And we just want to make sure that we're not blowing a vessel or anything like that. So now I'm going to take my drug. It's ketamine and midazolam. And we want to do an induction to effect, which means we don't want to give more than the patient needs. So I'm just going to do it slowly, make sure we're in. So I'm going to pay attention to the patient, see how he's doing. I can get a little bit more. Can check, test jaw tone. Still needs a little bit more. All of that. And then I can go ahead and give him the rest of the flush. Just a little bit. Okay. So I'm giving him the rest of the flush. Put our cap back on. And then we'll just give him a moment, and once he's ready, we can start to intubate. So first thing I'm going to do, I have my tubes over here, and they've all been tested to make sure that there is no leaking around the cuffs, so they were inflated, and they were tested so there's no holes or anything like that. So I'm going to go ahead, I'll try a 7, and how I want to measure how far down I'll go is going to the thoracic inlet and seeing where that falls at the tip of the nose. So around here is where I'll probably bring that down to. So Linda's going to hold open the mouth by the maxilla. And I'm going to get my gauze and hold the tongue down and out of the way. And I want to, with my tube, I want to push up the soft palate and push down the epiglottis so that I can see where the glottis and vocal folds are. And I want to gently, I don't want to force it in. I want to force the, put the tube down. And sometimes you can tell when the tube is in properly. The patient will cough. Sometimes they cough if they are deep enough. You can also see that there's a fog condensation when the patient exhales. I need my got my tie. And then you can also put your hand in front of the opening of the tube itself and do compressions on the lungs and see if you get any airflow coming out. So I'm just gonna make sure this doesn't get tangled. Tighten that so it stays in place. All right, so now we're going to put the patient in lateral recumbency. And put him on oxygen in the meantime. Make sure it's on. And I want to just make sure that my tube didn't go too far down into the trachea, into one of the bronchi, because that would mean that one of the lungs is getting air supply when the other isn't. So I'm just going to listen to both sides real quick. So I can hear air coming from both lungs, so that means that the trachea is in the correct spot. So now I am going to inflate our cuff. Linda is going to fill the reservoir bag with air, and I'm going to take my syringe, and I want to listen for any air escaping the cuff. That's a hissing noise. And once I'm sure that I don't hear it anymore, that means the cuff is properly inflated. One thing we do want to be mindful of is not overinflating the cuff, and you can tell that by looking at the manometer on the anesthesia machine. And basically, if you are hearing this hissing noise at a pressure of 20 centimeters of water, it should stop, and at a higher pressure, it should continue. But if it's overinflated, then that pressure, that noise that you're hearing won't stop, or will stop at a higher pressure. So our cuff is inflated properly. We can go ahead and turn on our isoflurane, and so we can prep the patient. And then the last thing I'm going to do is apply eye lubricant to the eyes to make sure that the eyes remain that the eyes don't get damaged during surgery. So we can put them on one. Another eye. And now we can start prepping our patient for surgery.